Okay, so today we'll be talking about myasthenia gravis and Lambert-Eaton syndrome. And so both of those are disorders of the ability to, of sort of muscle strength, essentially, which is why I have SpongeBob showing off his strength. And just to keep with our tradition of having the Poll Everywhere quiz for the previous class, we have a simple, well, a question about seizure types. Okay, so hopefully everyone has, one more second? Sure. Okay, I'll just start talking and leave it on this screen, so anyone who hasn't managed to log in, keep trying. So what kind of seizure would A be? Myoclonic, yes. And B? Tonic seizure. C would be atonic. And D is a clonic seizure. So, and these obviously, as I mentioned, although we didn't go into that aspect, because it's more sort of pharmacology and therapeutics, you actually use different anticonvulsant medications depending on the type of seizure people have. So this is sort of like, you know, it's not just a sort of diagnostic thing, it's actually relevant to sort of pharmacy practice. However, it has very little to do with the subject of today's class, which is, as I said, myasthenia gravis and Lambert-Eaton myasthenic syndrome. And so these are classed as myasthenic disorders. And those are like, there's a number of different types of disorders of this type, but they're basically something is going wrong at the neuromuscular junction. And obviously, since the neuromuscular junction is responsible for connecting your motor neurons to your muscle fibers, if something goes wrong just at that junction, then you lose the ability to sort of get, you know, typically this sort of presents as sort of muscle weakness rather than that your muscles actually sort of waste away. And, but it's, you know, like obviously a serious issue for the patients because, you know, like we're all, you know, obviously rely on functioning neuromuscular junctions every second of the day. And so there's a bunch of different things that can go wrong, ranging from, and it's basically any of the moving parts of synaptic transmission can go wrong. But the two sort of kind of archetypal ones for the neuromuscular junction itself are going to be Lambert-Eaton syndrome, which will be the second one we'll talk about. And this, as we'll discuss, relates to the calcium channels on the presynaptic terminal. And then myasthenia gravis, which relates to the acetylcholine receptors. So what would you see in a patient who had myasthenia gravis? It's one of its major signs is that So it's a myasthenic disorder. So it presents as muscle weakness, but that muscle weakness tends to develop over the course of a day. So right at the beginning of the day, like the patient is typically pretty functional, but by the end of the day they might really have severe sort of problems with many of the muscle groups. And typically you'll see this kind of regional distribution of the weaknesses. So in particular, facial muscles are particularly vulnerable to this. And so some of the clinical signs you'll see is that sort of the face will start to get kind of droopy. You have this ptosis, which is this sort of droopy eyes and so on. A patient will have trouble sort of resisting having their head pushed back, things like that. So it's kind of a floppy neck, if you like. And as I said, they'll get progressively sort of more and more exhausted and weak through the course of a day. And the sort of classic test for it used to be something called the tensilon test, after the brand name of this drug, edrophonium chloride. And the striking thing with this is that a patient with myasthenia gravis, will be all sort of kind of flopping around practically, and you give them this tensilon or edrophonium chloride, and within sort of a couple of minutes, they're sort of completely normal. So it's very striking, rapid recovery. And so that used to be the sort of major diagnostic test. And nowadays, because we know more about the underlying pathophysiology, the definitive test is actually the presence of antibodies against the acetylcholine receptor, which, as you would probably imagine, isn't a terribly good thing to have. So to sort of, yes. So this is pharmacology, but so the reason the tensilon is used is because it is very fast acting, and it does last for a very short period of time. However, other drugs in the same pharmacological class, so what tensilon does is it inhibits acetylcholinesterase. And so that means that acetylcholine persists at the synaptic cleft for longer, which means it can do more good stuff. And so drugs in that class that are longer lasting are the major treatment for myasthenia gravis. So obviously it's only a symptomatic relief. It's not, going to the root cause of the problem. So to kind of discuss what's going on in myasthenia gravis, we sort of need to sort of think slightly more depth about what is the neuromuscular junction. So obviously you have your presynaptic nerve terminal, which is obviously coming from one of the lower motor neurons in the spine, and then it'll contact the muscle fiber, and it has this kind of this on the left is the cartoon where you have cartoon of the organelles and so on. So you have your synaptic vesicles, and we can release those onto the muscle fiber, which has these characteristic folds. And then on the right hand side, we have more of the sort of biochemical cartoon of what's going on here. So we have we synthesize acetylcholine, we release it, and then this enzyme within the synaptic cleft, acetylcholinesterase, which we talked about a week or so ago, will then end its persistence in the synaptic cleft by breaking up acetylcholine into its two constituent parts. It breaks the ester bond. And so acetylcholine will bind to the acetylcholine receptor and then become degraded, and then the choline gets taken back into the presynaptic terminal. So these two factors, the organelles versus the sort of biochemistry, both of them are significant in this case. And then on the right, we just have an electron micrograph of a neuromuscular junction. And so this is, down here is the muscle fiber, and here is the presynaptic terminal with all of the synaptic vesicles in it. And you can see these are called the postsynaptic folds, and they're the actual acetylcholine receptors are actually present at the tip of these folds. And the fact that you have these folds extending into the muscle fiber is significant for speeding up the spread of excitation into the muscle fiber. The other thing that we need to know in order to sort of be able to sort of look at what's going on in myasthenia gravis and Lambert-Eaton syndrome is some way of measuring the connection between the nerves and the muscle. Obviously, you could do sort of like some kind of biopsy and electron microscopy or something like that, but that would be extremely time consuming to do for every patient. And it would also be kind of painful. And so the good thing is that we can do something very similar to the EEG that we talked about in the epilepsy class. And it's, instead of being called an EEG, it's called an EMG, an electromyogram. And what we're doing is, again, it's also very similar to the nerve conduction studies we were talking about with, when we were talking about the sense of touch, where you can sort of stimulate a finger and record the compound action potentials that are coming out. In this case, you're stimulating the nerves and recording the activation of the muscle fibers. So it's kind of flipped. And so what we can do is we stimulate the nerves and then just record the compound electrical activity of the muscles that are being activated. And so the more individual muscle fibers that are being recruited by the stimulation, the bigger the electrical signal that we'll get. And it turns out that if you use this technique, obviously you can use it to sort of study healthy volunteers and, like learn more about neuromuscular transmission. But if you look at patients who have myasthenia gravis, you get a very different appearance to the EMG. And so, some of the way that really shows up is if you change the frequency with which you're stimulating these nerves, or like stimulating the nerves, which are then stimulating the muscles. So, as you'd probably expect in normal volunteer patients, you can stimulate at low frequencies and they'll, respond well. You can stimulate at higher frequencies and they'll still, respond well. In patients with myasthenia gravis, if you give a single stimulus, and obviously there's no frequency for a single stimulus, they will give a normal muscle response. So to a single stimulus, normal response. But if you start giving repeated stimuli at, in this case, 3 Hertz stimulation, so a fairly low frequency, 3 times per second, they will, like a normal patient would, the response would remain constant, to each of these little pulses. Whereas in the patient who has myasthenia gravis, their muscle response will steadily shrink. And this is what, gives rise to the weakness, because it's like they're no longer able to, like when you're sort of, if I try to lift up this table, for example, which I won't because I'll probably get in trouble if I break it something. But like there's a continuous contraction of my muscles in order to sort of exert the force. So that's a lot of individual action potentials going down to the nerve terminal and telling my muscles to keep contracting. So if I had myasthenia gravis, I could sort of do that for, essentially, like, I don't know, couple of like 10 milliseconds or something like that, and then my muscle would get progressively weaker and unable to do anything. Interestingly, at higher frequencies, the response actually is a little bit different. And if you're recording the sort of muscle responses to this high frequency nerve stimulation, you'll actually see it's sort of weaker than it would be, and it kind of like ebbs and flows a little bit. But it's much better than the situation at low frequencies of stimulation. And what this is fundamentally saying is that there's sort of some problem with the sort of safety factors for neuromuscular transmission. So neuromuscular transmission is like one of those types of synapse where you don't really want it to sort of be very plastic. As in, you don't want that, like connection to sort of start learning, because it's the job of a neuromuscular junction is just to convert a signal in the presynaptic terminal into movement of the muscle. And for that reason, there's a large number of nerve terminals for each muscle fiber, and the whole idea of it is to sort of get one-to-one communication. You know, like it is like a direct connection. So in myasthenia gravis patients, we're no longer getting completely reliable neurotransmission in the connection between the motor nerves and the muscle fibers. And if you look in if you do take that sort of muscle biopsy and look at the neuromuscular junctions, you can see a difference in the neuromuscular junction from normal patients, normal volunteers to patients with myasthenia gravis. And this is kind of summarized in this cartoon. So again, on the left, we have a normal looking neuromuscular junction. On the right, we have one in myasthenia gravis. And you'll notice a couple of things. So these folds in the muscle fiber are greatly shrunk. And the number of acetylcholine receptors is also greatly reduced. And so those two factors are going to reduce the reliability of the transmission when you're releasing acetylcholine onto this muscle fiber. And it turns out that myasthenia gravis is an autoimmune disease. So this is why the presence of antibodies against the acetylcholine receptor is diagnostic for it. And so there are a number of different ways in which these antibodies can mess with neuromuscular transmission. So we can cause destruction of the actual surface of the muscle that has all of the acetylcholine receptors. And so this is through binding of the antibodies and activation of the complement cascades. And I believe Dr. Lindblad's probably talked a lot about that in the classes you've already had. So this is classic, antibody binding and recruitment of all these factors. They cause a direct attack on the surface of the muscle fiber. And so that is going to lead to this destruction of the regular morphology of the muscle folds, because it's continuously being attacked. It's just trying to heal itself as quick, as much as it can. It no longer has that sort of classic morphology. There is also the ability of these antibodies to bind. Obviously, they bind the acetylcholine receptor, and they'll cross-link them, which then leads to internalization of those receptors. And obviously, if you internalize the receptors through endocytosis, then they're not sitting there on the surface. They're not going to be able to bind any acetylcholine. So even though the protein might be there in the muscle fiber, it's not there on the surface, and so it's not going to be exposed to any acetylcholine. Therefore, again, you're going to reduce the level of activation you get following release of acetylcholine. And then the third route of attack is by blockade of the channels. So if the binding site for the antibody is basically covers the acetylcholine binding site on the receptor channel, then you're going to block acetylcholine binding. You're going to get a non-functional receptor. Similarly, if you have receptor binding that actually blocks the pore of the acetylcholine receptor, then even if acetylcholine binds, you're going to have no signal. So that kind of just direct inhibition of the receptor by the antibody is a third route of autoimmune attack in patients with myasthenia gravis. So what can we do about that? So as we discussed, there's the so the tensilon test is short lasting. However, other drugs that also inhibit acetylcholinesterase will increase essentially the safety factor of neurotransmission in these patients, which means that the acetylcholine that they do have will last longer in the synaptic cleft, which will then give stronger activation to these muscle fibers, which means that the patient then is more functional than they would otherwise be. Also, because it's but that obviously doesn't attack the root cause, which is obviously the presence of these antibodies against acetylcholine receptors. So you can do different immunomodulatory treatments. So whether you're talking about thymectomies or plasmapheresis or immune absorption, these are all different therapeutic approaches where you can actually try and tackle the root cause. And for example, immune absorption is to try and remove the antibodies from the patient, where so basically they're just continuously having their blood, like stripped of those particular antibodies, so that they therefore have less of an attack on their own bodies. And then there are generalized immunosuppressants as well, which of many different classes, which will also help these patients. And then there's some sort of experimental approaches, which again are tackling the immuno side of this disease, which could be depletion of specific populations of T or B cells that are involved in the attack in these particular patients. And then there's also approaches to reduce complement-based damage to the muscle fibers. So now we're not less rushed for time. So try and think of the key points and sort of summarize them to sort of in like your groups of two or more. Yes.
We'll see.
Okay, so let's get back to it. And so in myasthenia gravis patients, they get obviously develop this weakness. Why do they develop this weakness? Yes.
They have an autoimmune response that recognizes the acetylcholine receptors as a pathogen and starts attacking them. It does this in 3 separate ways: the lysine interaction, the blockade system, and full reassimilation into the muscle tissue. So can't contract, no response.
Yes. And so this is, and it's not like a complete loss of all of their acetylcholine receptors, because otherwise they would not be moving. Yes, yeah, they'd die. They wouldn't be able to breathe. And so, but because they're losing a chunk of them, they're losing this safety factor, and so that transmission is going to be impaired. And I'm going to, for the next class, I'm going to print out a pack of cards of all of your names. And so I'm going, for these bits, I'm going to pull names out at random. So, just warning. But this is just like, you know, like it helps everyone, I think, to sort of try and talk about these things, because then, you know, like it kind of cements it. So the second of these disorders is Lambert-Eaton myasthenic syndrome. And again, it's an autoimmune disorder. And again, it causes muscle weakness. In the case of Lambert-Eaton syndrome, it's actually a little, yes? No. So that would be the case if you lost all of your acetylcholine receptors, but that, to my knowledge, does not happen. So the most severe patients have really pronounced, you know, weakness even with sort of treatment, and so they have, you know, like relatively poor quality of life and so on, and probably some of these morbidities that go with impaired mobility and things like that, where you have risk of, you know, like lung issues and things like that. But it in itself is not a fatal disease. Whereas I think it might be Friday's class when we're talking about ALS is, you know, like, and it's also in a very different way related to muscle function. So in Lambert-Eaton syndrome, there are about half the patients are sort of like directly analogous really to myasthenia gravis patients, in the sense that it's an autoimmune attack on the neuromuscular junction function. However, there's about half of patients who develop Lambert-Eaton syndrome actually have small cell lung carcinoma. And that's related, because it's related to the sort of overgrowth of cells which are generating the antibodies, which then lead to this attack. The symptoms of Lambert-Eaton myasthenic syndrome are in some ways similar to myasthenia gravis, because we're talking about this muscular weakness. However, it affects different muscle groups. In particular, it affects some of the large muscles. So now the patients are having they're not having sort of droopy heads and overall fatigue, they're having sort of trouble walking. But there is still weakness in eyes, face, and throat, and speech impairments and swallowing problems. However, it is a pretty rare disorder. The reason that sort of myasthenia gravis and Lambert-Eaton are often taught kind of side by side is because they sort of illustrate two different aspects of neuromuscular transmission. Because myasthenia gravis, as we've just talked about, is an attack by the immune system on the postsynaptic receptors, so the acetylcholine receptors on the muscle fibers. In Lambert-Eaton, we're talking about an attack by the immune system on presynaptic proteins, specifically the voltage-gated calcium channels on the presynaptic terminal. And to sort of explain what's going on, it's sort of helpful to talk about synaptic transmission again. So this is just like what we've already talked about. So we have an action potential that gets into the nerve terminal. And what does it do? So obviously it causes a wave of depolarization. That wave of depolarization at the nerve terminal causes the opening of these voltage-gated calcium channels. That means that calcium is coming in to the presynaptic terminal, where it can bind to synaptotagmin, which is this calcium sensor. That leads to activation of the snare complex for causing vesicular fusion with the plasma membrane. The neurotransmitter, acetylcholine in this case, is then released from those vesicles so it can diffuse that very tiny distance across the synaptic cleft, where it will then obviously bind to the acetylcholine receptors. So that's going to be for today's class, two areas where the immune system is messing with neuromuscular transmission, the presynaptic side and the postsynaptic side. If we look, again, using the electromyography, we can sort of look at in exactly the same way, we can look at the relationship between nerve stimulation and muscle response. And so again, at low frequencies, we have, for a normal patient, like we have like a one-to-one response. Every nerve stimulus will give us, like a good sort of muscle twitch. In patients with Lambert-Eaton syndrome, you get nothing. So, like it's kind of dead. However, and interestingly, if you go to a higher frequency of stimulation, obviously normal patients will give this big burst of twitches, a strong muscle response. In Lambert-Eaton syndrome patients, what you'll see is they go from having no muscle response to actually a real response. So this is what's shown down here. So you start with almost nothing, and then it progressively gets stronger and stronger and stronger. So that's kind of interesting, right? It's like almost the exact opposite of what you'd see in the myasthenia gravis patients. And the explanation for that ties into sort of how the immune system is attacking the neuromuscular junction in these Lambert-Eaton syndrome patients. So it's attacking the calcium channels. And calcium behaves in a particular way in presynaptic terminals, which is if you stimulate a nerve terminal at a low frequency and measure the entry of calcium into that nerve terminal, you can see it basically, for each action potential that invades the nerve terminal, a little bit of calcium comes in. And that, will typically be enough to cause, like vesicular fusion, especially at the neuromuscular junction. So you keep stimulating at a low frequency, you keep getting little calcium spikes that drop back to baseline. If you stimulate at a high frequency, however, you see that the calcium no longer drops down because the next action potential arrives before it's dropped down. So if we come back down here, so you see this little calcium signal. If I gave another action potential, like right here where my little red cursor is, you'd see this would occur, but it would be on top of the existing one. And that's what you have up here. So we have the action potentials arriving on top of one another, and so the calcium starts building up. And the higher the frequency, the faster that calcium will build up. And this is actually a phenomena at all synapses where you get high frequency stimulation and you can get something called synaptic facilitation, which is driven by this accumulation of calcium presynaptically, because the calcium is coming in quicker than it would otherwise drop back down again as a result of being pumped out of the cell and pumped into internal stores and so on. So in the explanation for this phenomenon in myasthenia gravis patients is that their calcium channels are greatly reduced in number. So they get very little calcium in to a single action potential. But if you start giving lots of action potentials, they start getting, even that tiny little bit of calcium starts building up. And so you start having this phenomenon where the calcium is building up. And now it's enough calcium getting in to actually cause significant release of acetylcholine, which means that finally you actually have functional muscles again. So it's a very different appearance to what you'd see in the myasthenia gravis patients. And it also leads to another question, which I'm sure you were all asking yourselves. So given muscle contraction is also driven by calcium, why is the muscle able to contract at all? Why doesn't the nerve terminal go down and the muscle go down? And the answer for that is that there are different types of calcium channels. And they're all found in very many different types of neurons, and also obviously in muscles, smooth muscle versus skeletal muscle, and so on. And so the nerve terminals that we're concerned about for the neuromuscular, the presynaptic side of the neuromuscular junction, are these PQ type channels. Whereas the ones that are required for skeletal muscle contraction are L-type calcium channels. And just as a sort of digression, these T-type calcium channels are called T-type because they're found in the thalamus, and they're the ones that actually are involved in absence seizures. And so there's a particular drug that targets just those channels that is the treatment for absence seizures. However, as I said, digression. But the PQ channels are the ones that are attacked in Lambert-Eaton syndrome. And so this is why we have this specific, particular level of loss of function at those, the presynaptic terminals of lower motor neurons. And we have very little effect on other neuromuscular transmission. Yes.
How does this all translate to movement on the leg? Does it still have any movement, or is it struggling or even?
So that comes down to, let's go back to, so it's like things where you have to do, it's an overall sort of impaired response. So it's always bad, essentially. So like with myasthenia gravis, you have the patients who, in many cases, are pretty normal first thing in the morning, and then they kind of degrade through the day. In Lambert-Eaton syndrome, they all tend to be sort of, all the time. So it's like a, like permanent, weakness. In terms of the functionality of sort of like how, like whether or not they can sort of like, what actions they can carry out. We are, like postural muscles, for example, are always going to be active, but typically at a kind of tick over type rate. So they will generally not be showing very much. They'll be stimulated at a frequency that these patients are able to stand, for example. You might think that they would be able to more able to sort of like say, run or something like that than they would walk. But because of this sort of pronounced weakness, they have this other side issue, which is going to be that their presynaptic terminals and muscle fibers, they're not like atrophying, but they don't have that level of training for sort of like being able to sort of really exert themselves, because obviously it's something that's difficult for them. So this is why they're not able to sort of think, oh, I can't walk, but I could run. They like that initial weakness sort of is hard to overcome for them. So. So as far as treatments for this, they're going to look fairly similar to myasthenia gravis with just a couple of differences. So, we can try and treat them by, depleting, like aspects of their immune system with plasmapheresis. And we can also treat with acetylcholinesterase inhibitors. And so the idea of that is, okay, we're having trouble releasing acetylcholine consistently because we don't have these enough presynaptic calcium channels, but we do get some acetylcholine out. So if we give an acetylcholinesterase inhibitor, the little bit that comes out will have a better chance of activating the muscle fibers. And then there's one other approach we can use, because this is specifically presynaptic now, and that is doing something to make the action potentials work harder. And the drug that's clinically used to do this is, 3,4-diaminopyridine, which is amifampridine, in terms of what it will typically be called. And what this does is block potassium channels. And what do potassium channels do in the action potential? They cause the downstroke of the action potential. So if you use a drug that blocks potassium channels, and I couldn't easily find a good picture for this particular drug, so I chose a picture with a different drug that blocks potassium channels, DEA, tetraethyl ammonium. And so you can see as you add the potassium channel blocker, the action potential gets broader and broader. So what happens if the action potential gets broader? That means that there's a longer time for the voltage-gated calcium channels to be open. So even if you have fewer of the channels that are functional, you can get more calcium in per action potential, which means that then you can have a greater functionality in terms of transmitter release. So the final thing I want to talk about is there are like a few different drugs that actually can exacerbate these disorders. And some of them are fairly obvious, like muscle relaxants. Who thinks it would be a good idea to give someone with myasthenia gravis a muscle relaxant? It's like, like they're going to be sensitive to it because they can barely get their muscles working anyway. Same thing with sort of local anesthetics. It's like you have a problem with neuromuscular transmission, like you don't want to, risk causing, like loss of respiration or something like that. Magnesium may be less obvious because, but it actually does cause a reduction in acetylcholine release by partially blocking the calcium channels. Botulinum toxins, also potentially a problem because, again, if you remember, they actually cleave the proteins responsible for neurotransmitter release. So you've got to be careful with those. But the thing that is probably least obvious is going to be antibiotics. So there's a number of antibiotics which have an ability to interfere with transmitter release. And so it's not a problem for the general population. But for those people who have impaired neuromuscular transmission, it does become a problem. And the exceptional drug, which may actually have been withdrawn now, is this antibiotic telithromycin, which actually will, in many cases, kill patients with this kind of condition. And the reason for that is nothing to do with, obviously, its antibiotic activity. It's due to the fact that it actually acts as a nicotinic acetylcholine receptor antagonist. So it blocks the receptors. And so again, if like, last thing you want to give to someone, like, who has this kind of myasthenic disorder. And we actually have time for you guys to actually talk about this stuff. Someone testing your muscle synapses? I have that. I assume you have. That's all it takes me to wake up. Because of snow? Oh, wow. Raining. Yeah.
It started snowing by the time I got here.
Okay. Okay, so what are we finding for the differences between myasthenia gravis and Lambert-Eaton syndrome? Sure. Yes, yes, the EQ, PQ. The L-type ones are in the muscle. Yeah, and so as a basic question, so which is myasthenia gravis affects which part of the synapse? Exactly, and Lambert-Eaton syndrome affects presynaptic. Yes, and so it's like one of them is affecting the release of neurotransmitter, the other one is affecting the ability of the muscle fiber to respond to that neurotransmitter. But both of them, because they're affecting the neuromuscular junction synapse, are going to lead to this muscle weakness. Yes?
So what if they have to have surgery? Like putting them under really affect them?
You would, so it would, and you would need to have, basically they'd need to be, it is definitely sort of make sure that they know about it beforehand, because actually you'd have a similar issue with ALS patients, but you need, because there's this very limited safety factor, whilst you're in surgery, you'd be fine, because basically they kind of don't let your body do anything anyway. So they do the breathing and everything for you. But yes, you'd have to be in the patient would have to be in sort of full intensive care after surgery, not just the normal PICU type thing. So they are, like going to have major issues. And then for surgery, you also have give patients muscle relaxants for obvious reasons, and so you would want to sort of do very minimal doses and things like that. But yes, it would be a big headache for the team involved. And so again, we have these study questions to sort of kind of help you approach the PowerPoint slides, so that if you can really answer all of these questions sort of in depth, then you should be good to go, and it'll have been a successful class. And so I think actually I need to stop recording.